You guys here? Yes. Oh, like, yeah, by the way, lichen planus, which is the 5P, maybe pruritus, polygonal, least purple. Yeah, maybe we can put it here. I think I will put it there. Yeah, you are right. This is the two nodules. I mean, the Wartic one. Yeah, I forget to mention it here, but I will talk it. I will talk about the Wartic, not the Wartic, small nodular lesions. Yeah, I don't know where I put it because now it will be too much. You have Wartic, and you are differential diagnosis molluscum, and lichens here. Okay, I will talk about these details, but nodular. No, it's high yield. I got it. I got in step one and step two. It's high yield. Molluscum contagiosum is high yield. Erythema young risk factors for acne. All of you know. I don't think the clinical features for acne or rosacea, or for acne, I'm sure, but will be. I don't think will be questions for risk factors or clinical features for acne. Usually, acne questions more with the treatment, but just in case, the most common risk factors usually, I'm not sure the most common, but the risk factors in general, just male, young patient, maybe he's on steroid, maybe he's on case of Cushing disease, maybe he's taking some other medications, androgens, too much androgens, or maybe he has just oil complexion. Older patient risk factors for rosacea. This is interesting, which basically either the patient have, not the patient, usually triggered, you can say triggered by what? What is the main things that trigger rosacea? One or two things. Alcohol, number one, hot environment or temperature, which is hot environment, or one environment, or any emotional stress. Three things, guys. You will see it in the test. The patient, when he will stress, he will get erythema, and then when he drink alcohol, he get erythema. He stopped alcohol, erythema less. What is this erythema looks like? Just erythema on the face, which is small erythematous lesions. Maybe you'll put this face looks like this. These erythematous lesions. Now the interesting things around the erythematous lesions, there is, I sure don't know how to draw it, but there is something with erythematous lesions. So you can say erythematous, and the specific things here with the erythema is telangiectasia. While the specific things for acne plus negative, this is plus negative, this is not 100% comedone. Alright, so comedones, which is basically either closed or open. What is this comedones? Just uh, inflammation, the sebaceous follicles, right? The sebaceous follicle inflammation and then obstruction of the sebaceous follicle just make these comedones formation, whether it's obstructed or non-obstructed. So comedones here is interesting. Telangiectasia and rosacea is I think it's a kind of more specific because both of them maybe the face will be the same, guys. So both of them usually small erythematous lesion, acne-like features. Rosacea also acne, but maybe rosacea will be diffuse in the nose. So this is the whole nose will get rosacea and the whole nose very red, and I think they call it rhinophema. I don't think the term is important, but just in case, the whole nose, rhinofema, and this usually after stress, rhinofema. Now, how about the treatment? Metronidazole is here affected if it is not, if the patient not get, after metronidazole still problems, so we'll go with the systematic antibiotics like tetracycline. So here we can say, and this metronidazole basically is a gel, it's not systematic. Metronidazole is local or gel, and then still there is a problem, we'll go with systemic antibiotics. And I'm talking about systemic antibiotics here, and we are talking about tetracycline. How about the acne patient? Very high yield approach. If there is mild, hey, what's the problem? Yeah, if there is mild, you will go with topical in general. So always mild, remember topical. Mild or moderate, maybe. Now for topical, you will start. Look at the start. You will start first. This is your topical start. So you will put benzyl peroxide here, which is, you first start with benzyl peroxide. Still there is a problem, you have to add, not alternatives. You will add here retinoids, which is also topical. Still a problem, you will add, what you will add at the end, also topical, either clindamycin or erythromycin. So you will add typical clinda or erythromycin. Very high yield, guys, and it's not so hard. Now, for mild or moderate, the key point is topical. First, you will start, this is your start point. You will start with benzyl peroxide. Okay, topical. Then still a problem, you will add retinoid. Topical. Still a problem, you will add clindamycin, erythromycin, but make sure, still I am talking about topical agents. Is this hard? Now, still a problem, the patient now go to another category, which is the severe form. So maybe we can put, I will delete this comedone because I will make the comedone on the left side. Give me a few minutes. Maybe now you can work and you can go with another category, which is severe form, right? So here basically you'll get the second form, which is moderate to severe, and this is usually nodular pustules. So what I mean by severe forms, usually pustules and nodules and a lot of scars. This is now severe, guys. Not just erythema. Erythema mild. This is just erythema. You'll go with mild and moderate. But how you will know in the questions that it is severe? You will see either scar, pustules, nodules. So you are talking now about the severe form. So you will not do the topical one. You will start with systemic systemic things. So basically here your answer will be systemic. What is your start? You start with first start point, which basically antibiotics. Sorry, you will start with antibiotics, tetracycline, doxy, clinda, whatever the antibiotic is, but start with tetracycline. Still a problem. Here you will add retinoid or isotretinoin, which is basically vitamin A. So you'll add retinoid here. So now will be easy retinoid indication. Retinoid indication, basically patient severe, not responding to antibiotics. Now it will be easy, what will be the answer for antibiotic? Is severe, first initial treatment for severe is just antibiotic. Now topical, resistant to retinoid, you will add clindamycin. Now topical, not improved by benzyl peroxide, you will add retinoid. Now topical, retinoid and benzyl peroxide, you will add clindamycin. So it's really not hard. Just according, this is a guideline, guys. It's not from me, not from specific book. This is guidelines. So it's definitely, if there is a question, it will be around one of these, either which one you will use, and it's not so hard, by the way. Any question? Where? In systemic, you mean? In systemic, the first, yeah, the first choice you will go with antibiotic, Alex. All right, and then you will add retinoid. Okay, so the retinoid indication after antibiotics and severe. Er, Yeah, in a pregnant patient, you will not do retinoid. This usually in a pregnant patient, the question will be retinoid contraindication. So maybe you will stop with systemic antibiotics. I don't think in a pregnant patient she couldn't you couldn't give her tetracycline because tetracycline is also contraindication. But I think you can give erythromycin. I'm not sure you can give. I think erythromycin. Clinda in a pregnant patient it's safe, right? Anyone remember Clinda? I think clindamycin is okay in a pregnant patient. So you will stop with systemic antibiotics in a clinda in a pregnant. Yeah, I don't have problem with the topics, but I'm talking about the severe. Ah, you mean topical retinoid in pregnancy? I don't think they will. Yeah, I don't think it's. I think it's also a contraindication. That's what I think. I'm not sure about this topical. It's interesting questions, but I don't think they will use it because it's highly teratogenic, and this part of the topical will go to the blood, right? And it's usually days. I mean weeks of treatment, not just one day. So even topical, don't use it. Although I don't know, guys, exactly. By the way, the answer for these questions, but I feel no. Any question? Is that clear? The approach for acne. Okay, let's move. So you got two diseases so far, which is erythema, metronidazole gel 1 and tetracycline. So maybe we'll see the answer, which they like it sometimes. The answer of metronidazole gel will be rosacea. The answer for benzoyl peroxide, you will just go with acne. So we're done with two. So I'm still in erythema questions. Painful erythema. Maybe this is the only time, guys, when you will see painful erythema, and usually this is the leg, let's say this is the lower limb, and basically here is the erythema in the shin, looks like this, and it's spread painful. The answer, very good. So here erythema nodosum, and erythema nodosum you have a lot of differential diagnosis. So maybe you need to do chest x-ray for the patient, or maybe you need to do SAO titer, or what else, maybe you need to do colonoscopy, right? What else? Anybody remember some other investigations? So maybe here we got colonoscopy, we got chest X-ray, and chest X-ray. When I'm talking about chest X-ray, you have two differential, by the way, for thimonidosum, chest X-ray, ASO titer. What else? Maybe the patient have drugs problems, which is usually, or or yeah, which is usually. No, let's make the drugs another way. Maybe the patient have an increase in hormones. Some of the hormones is just maybe high, which is basically too differential. Or maybe the patient have sexual history, so sexual problem. Or lastly, the patient have recurrent oral ulcers and genital ulcers. So recurrent oral genital ulcers plus I. All of that, guys, the differential diagnosis of erythema nodosum. Now, give me the answer for the first one. The chest X-ray finding, not chest X-ray finding, I mean chest X-ray diagnosis in erythema nodosum. What would be? Very good. So it will be, so that's easy. It will be here sarcoid and TB. How about ASO titer? Just stripped. No, rheumatic fever is no. Just streptococcal infections. which could be rheumatic, but in rheumatic, yeah, in rheumatic will not present erythema nodosum. Streptococcal infection, which is the regular strep in the acute sore throat. Colonoscopy, inflammatory bowel disease. In increased hormone, I'm talking about estrogen, oral contraceptive pills, pregnancy, sexual syphilis, orogenital ulcers, and eye. What is that? Come on, in Middle East. Budget. No, this is budget disease. It's very common in Middle, not very common. I mean more prevalence there in Middle East. Behja, the name of the scientist, I think Turkish. So what else? Medications. Maybe you can put medications here, like sulfa drugs, like amiodarone. So medications, two medications important: sulfa and amiodarone. Now, although it's a lot, how about the question wise? Sure, you know the questions either will be about sarcoid or inflammatory bowel. Yeah, I think that's it. I don't think this. I think that the rest is just too much. Is there any treatment here? Questions? No. Nobody will ask about treatment for that. Maybe just non-steroidal. So we're done with this erythema nodosum. I'm just memorizing stuff. Now target lesion, and this target lesion with erythematous macules. So here you will see these macules. This is macule with a kind of target lesion. So we'll say this target lesion. So the answer will be erythema multiformis. Now, the patient got more severe symptoms. What I mean by severe symptoms may be hemodynamic unstable or maybe diffuse. So this erythema multiformis, maybe you can say localized, but if you get extensive disease, a plus toxic patient. What I mean by toxic, I mean hemodynamic unstable or the patient is really sick. Now you will name it as what? Steven Johnson syndrome. Steven Johnson syndrome, which is the same as erythema multiforme, but it's just severe form. Now, still more severe form. Maybe you can say here the hemodynamic unstable. What you will name it? Very good. Toxic epidermal necrolysis. So, guys, it's not so hard. All of them represent one pathology, which is it started as macules, small target, localized, then get more diffuse. You'll go with Steven Johnson. More diffuse now and hemodynamic unstable patients, very sick, very wherever. You'll go with toxic epidermal necrosis. Now, one question here in erythema multiformis: what is the virus that associated or could be presenting as erythema multiformis? What is the virus here? Yeah, right. So herpes zoster virus could present as erythema multiformis. Okay, this is important. Hey, Michael, please make it mute. There is some hammer like yeah. So herpes zoster virus is here. Now, how about the other causes in general for erythema multiformis or the all of them one? Guys, the drugs are big time. Interesting things about allopurinol question. Sulfa, I think sulfa questions is easy. So sulfa, most of you know. Allopurinol here. The same, guys. I don't think I need to make another list for Steven Johnson. So you can put the same list: sulfa, allopurinol, all of these lists. It will be the same. Sulfa, allopurinol. What next? Maybe barbiturate, phenytoin. By the way, right? If you remember, phenytoin also maybe barbiturate. That's it. I think that's it about drugs. So what else? Also interesting. Go ahead. I mean, yeah. No, no, no. Because this is one of the side effects of the drug. Just maybe 1%. I'm not sure. It's really rare, but no, this is one of the side effects of sulfa. I don't think this is this is. I don't think the pathology is allergic. It's not hypersensitivity reaction. That's what I remember. But I mean, uh, no one will sue you because of that, because this is one of the side effects. I don't know. Did I answer your questions? I mean, you're trying to say, is there any way to prevent this, right? No. Yeah, no. No way. Right. Right. It's happened to some people. I don't know exactly why, but there is no way to prevent it. I mean, no way. If you give Salfa to 100 people, one of them will have Steven Johnson. How? Why? How we will prevent it? I don't know. And I don't think there is prevention. Yeah, I mean, it's not like penicillin allergy. Maybe penicillin allergy, you can do this skin test, right? You'll do skin test in penicillin, and to see if it is allergic, you will not give it. But here it is not the case. Here you have to give the patient the drug and see, because yeah, it's terrible. Yeah, but